Okay, sorry, I think I got a call in. Uh, uh, yes, we've been running, and sorry, the mpox epidemic has been ongoing, and we know the numbers are many. And I want to thank all of you for the support that you've given to support this in picking up the samples, sample transportation, and the testing team. But on the 20th, that unfortunately we really need to be very vigilant as the health workers. I started with a health worker and started in Kampala, but as we speak, we also have an epicenter in Bali. So the ministry, as a lab pillar, we obliged to inform all our responders about the current situation and what is currently being done. And I know all are going to take you through the different areas that need to be acted upon. But as we speak, we have 3 testing laboratories at the center to support the reference testing. But because of the turnaround time and quick response, we've deployed a mobile lab in Bali. And as I was saying that as the labs, we really need to take lead. For example, in Mubende, the Mubende regional lab team really took lead working with the districts to make sure that the lab response was up to speed in terms of testing and also sample collection and taking charge of the trainings in the different districts that the region overtakes. Same applies to Mbale. That's what is going to happen to support the Mbale region in sample collection, the trainings, and the training materials, the different issues to handle in terms of biosafety, biosecurity. So we feel that you need to get up to speed, and I'm here to call upon you to support this response that is amid these different challenges that you've already been raising. We are a bit low on some transportation because of the orders you all know about, so that we are using the limited resources we have to support the transportation. So, and usually I know the lab people are usually contacted first when there's an outbreak. So as we shall hear the coordination, please reach out such that we are able to have those samples transported to the appropriate places. But I urge all of you to really be vigilant, support us in this response such that we can easily have it come to an end as we did. So I'm glad that we've attended in such good numbers, and please take this information lower to whoever hasn't attended. And we are also finally going to have physical trainings to the high risk districts such that we can have hands-on for the teams to be able to be up to speed, but do everything in a safe manner. So thank you so much. And I want to hand over back to the chair. Back to you, Morgan. Thank you.
Yes, so thank you, Dr. Susan. And I think Dr. Susan makes very key points that I will not repeat. We have all heard. We have to see the National Laboratory Network really doing its best, coordinating and working together. The national reference labs, we have mentioned about this, and they're already operational, like she has mentioned, 3 of them, including the mobile lab. The district and regional coordination that should happen for the regional and district level for sample collection and transportation and results management, and the physical trainings that would be coming upon to enhance and support all the virtual trainings that we are having. So, Dr. Son, I want to thank you so much for gracing this occasion and this very same time that we are having this session. I know you're quite busy, but we shall let you drop off at some point in time if really engaged. But I would like to thank you, colleagues, for joining in the shortest time, and we're over 300 on this call. I really appreciate. And I want us to dive into the presentations. For those who are not Ugandans, we really most welcome you to this call. We are grateful for the Umlta, for the extended support, for ensuring that we can cut across outside Uganda. It's a very big regional capacity. I really appreciate that from the Umlta team and NHLDS and the Ministry of Health. So right now, allow us to dive into the presentations, colleagues. I said for any questions you do have, we have experts on the call. We shall answer the questions. And for anything, let's always mute our phones and raise up your hand after the presentations for questions and also maybe clarity where we feel we have not explained things right. So right now, allow me to invite Winnie to come in. I told you she's a laboratory scientist with a public health background. She currently is the laboratory officer at WHO, and she's supporting us strongly as well as we implement and also contain these epidemics in the country. So Winnie, you're most welcome. please take the center stage, and you have about 10 to 12 minutes to go through your presentation.
All right. Thank you so much, Morgan, and thank you very much, colleagues, for joining. A very good afternoon to everyone. Yes, my name is Winya Gwang. I'm a laboratory officer with the World Health Organization, and I'm really happy to be here to discuss with our teams, because I don't think these are new concepts. We've been trained over and over. It's just a reminder so that we can be able to protect ourselves and keep safe, so that we don't have any laboratory personnel getting infected as the outbreak progresses, and also be able to contribute to the outbreak. So without further ado, allow me dive into the presentation. Kindly next slide. Yes, thank you very much. So we're going to look at the overview of EVD, that's Ebola virus disease, and MVD, Marburg virus disease. I bet you're wondering, why do we have EVD and MVD? This is because these two present more or less the same. And so sometimes we test for both of them. I should really thank the testing laboratories, because every time we get a suspect, they usually run all the VHFs. So that's why we have this as EVD and MVD. And the principles are more or less the same. They don't change. That's why we have them as such. So Ebola is an enveloped RNA virus with the lipid layer. It belongs to the ortho Ebola virus, and then it's single-stranded within the Filoviridae family. There are 6 species of Ebola that are known, and they are the Bombali virus. The Bombali virus was discovered in Sierra Leone by some researchers from the US. And then the Bundibujo virus was here in Uganda. The Reston virus was discovered in Reston. So you see that all our viruses somehow have their naming from their origins, but this is being discouraged currently because it causes some bit of stigma. And then the Sudan virus, the one that we currently have, is also from Africa, Sudan. And then the Thai virus is from also West Africa, from Cote d'Ivoire. And then the Ebola Zaire, which you call the EBOLA, is from the Zaire currently, the DRC. So the Marburg virus, like I mentioned before, is here because it presents with more or less the same presentation as the EVD. And there are currently 2 species that we know of, the Marburg virus and then the Ravin virus. So this presents more or less the same way. Just maybe key to mention is that the envelope has filaments that aid in attachment to the host cell, and then the infection without showing the symptoms. Next slide, please. The human let me begin from, it is a zoonotic disease. So it moves from animals to humans and can move also from humans to animals, though typically it's animals to humans. And for the human to human transmission, EVD begins in a population where there is spillover. When spillover occurs, that's how it comes into the human population. And its case fatality rate is about 25 to 90%. 25 is when we're able to detect it early, that fatality rate is a bit low. But if we take time to detect it, then the fatality rate is really high. It can even go up to 100, just like Morgan mentioned earlier on. So this is the range for the fatality rate, but it could be lower or it could be higher depending on the time we are able to detect the virus. So let me first talk about the spillover, which is on our right, those 2 diagrams. So the first one is looking at the different hosts of the virus. So the bat is the reservoir, it's a reservoir host. And the bats reside in the environment, reside in forests, reside in caves. And then the second part is the primate, the non-human primates. Those are the intermediate hosts. So this can pick the virus from the reservoir and then bring it into the human population, because we are always in touch with the environment. We go to the forest, we are clearing the forest, we're encroaching on the environment. So we find that we are going to get into contact with the reservoirs as well as the intermediate hosts. So when it comes to into the human host are definitive host. That's where the amplification takes place, and then the virus is able to manifest in its full potential. That's why we have very many days when it affects the humans. Of course, even the animals, as I'll explain in the next picture, even the animals get sick and then they die. So when we come down, what do we now see in the different phases? So when the virus is in the reservoir, we should always be prepared. So our preparedness comes in. What are we doing as preparedness as laboratory? We'll look at that. But then if it now moves to the alert phase, now it is in the intermediate hosts. That's when now we have to be alert. For example, you find that the primates are dying. You always get those signals. Animals are dying, so you will obviously think that maybe it is Ebola virus. So when it spills into humans, if we're able to control it in the alert, we'll be able to control it when it spills into the human population, because we already have the signals that look, the virus must be in the humans, in the animal population. So it's now moving to the human population. So as the response teams, will be able to prepare ourselves. And when it affects us, it's not going to be as high as it is, as we can see in the first diagram. There we have about 80 cases because we did not prepare. But if it finds us prepared, we shall be able to arrest it early and control it within the shortest time possible. You can even see the number of days if you do not intervene on time, if you do not prepare and have the alerts properly circulated, it's going to attack you unaware, and then you're going to have a number of cases, and it's going to take a very long time. But if it finds you prepared, you're going to take a shorter time and have fewer cases. So after the outbreak is done, we should always endeavor to evaluate our performance as a response, but also as laboratory. How did we perform? And in the evaluation, we're looking at things like interaction review. This happened as the outbreak is ongoing, maybe a few weeks or a few months into the outbreak, you can do an interaction review, but also you can do an after action review. So that can help you understand where you went wrong, what did you have in place, what lessons have you drawn from the outbreak, and how can you improve the outbreak as you move on, or in case another outbreak occurs. So this now brings us to building our system. So when you evaluate, you're able to put in place measures and build your system. In case the next outbreak comes in, you're able to contain it with the least mortalities and the least morbidities. So from the person-to-person transmission, colleagues, we go back to our left. Forgive me for taking right and left. I had to explain the transmissions. So in the person-to-person, so how do we get the virus as people? So as people, we'll get it from direct contact with the blood of an infected person. The different secretions, which are urine, saliva, we saw in the previous outbreak, that can even be in milk and semen. So we can get the virus from the different secretions, but also the organs. We can get if you come into contact with infected organs, we can be able to get the virus. And then other fluids and materials of the infected person, the beddings and their surroundings. So when someone has Ebola, we go and code off that area and make sure we disinfect everything, like everything, even your phone, your computer, as long as it has anything to do with Ebola, it will be disinfected and destroyed. That is how infectious the organism is. And then also the burial ceremonies that we have also contribute towards transmission of the viruses. We wash the bodies, and then also there's some processes where they have to remove the internal organs. So all those burial practices, some people sleep with their bodies, the widows or the widowers want to hug the bodies. So all those burial ceremonies also contribute towards the Ebola transmission. And then the health facilities and travel significantly contribute the spread of EVD in the human population, because we're in a global village. Right now, I can be in Kampala, and in the next 5 hours, I am maybe in Kisoro, and before you know it, I'm in Rwanda. Within a day, I can move to like all the East African countries if I have the funds. So you can look that someone can move from Uganda and take the virus to TZ, take it to Kenya, take it. So that travel facilitates the spread of Ebola. That's why we really have to be vigilant at our points of entry, in our bus stations, everywhere that we have any means of transport to avoid spreading the virus. So during these outbreaks, what do we really require people to do? We require strict compliance with biosafety guidelines. Colleagues, I cannot emphasize this enough. I do not know which language to use, but biosafety is the key to prevention of infection during the outbreaks. So how is that? Appropriate laboratory practices. We all know that good laboratory practices. PPE, do not eat in the laboratory, and do not move out with the lab coats, do not do this. So we all know those laboratory practices. Then we have the IPC precautions. We have the barrier nursing procedures. So when we have a patient that was usually isolated, so before you get in there, you're not a superpower, because when you get infected, you're going to join that team, and then you're going to reduce on our workforce out here. So we have the barrier nursing, where the people who are sick are really isolated, and then the people who are attending to them are given PPE, and then we have to use PPE. Sometimes laboratorians feel like, I have been in this outbreak for a very long time. I know how to handle the virus. I will sanitize, I will do this. But colleagues, PPE is very key. And please, it has to be full PPE. There is no shortcut for PPE. There is no saying, I don't have another pair of gloves, let me do. I don't have a coverall, this will be sufficient. No, please ask for PPE. If you do not have, we shall do our best to get you the PPE from the national level. And then disinfection of contaminated objects and areas before they are reused, if they are reusable, and the areas should be disinfected with 0.5% bleach. Please do not use ethanol, because as you shall see in the later slides, I'm going to explain to you why we prefer to use 0.5% jig. We should be prepared on a daily basis. Again, you'll get an explanation as we go ahead. And then we need to practice safe barriers. That's why you have the safe dignified teams trained to do these barriers, and not for everyone. You have to be trained before you conduct a safe and dignified barrier. So for us to be able to contain an outbreak, we need to break the chains of transmission. Unfortunately, I don't have a slide for that, but the different chains from the host, you can either remove the host, that's why we do isolation, that we remove the host from circulation, and then remove the means of transfer, the different objects, you clean the surfaces. So all those are removing any means of transmission. You can remove the reservoirs, but that may be a bit hard because we cannot go to the forest and kill all the bats. So we can focus our efforts where we are able to control and break the chains of transmission. Next slide, please. Yeah, so this is a timeline of our current index case. Unfortunately, he passed on, may he so rest in peace. But this is how the virus evolved over time until we're able to identify it. So the incubation period for Ebola is typically 3 to 10 days, but it can range from 2 to 21 days. So that is why we have to isolate our contacts. We follow them up. We don't isolate them, apologies. We follow them up for a period of 21 days, because by then we feel like they should now be safe if they don't have symptoms. But it doesn't mean that it cannot go beyond 21 days, but that is just the average, 2 to 21 days. So I'll take you through the timeline of our index case. So on the 19th, and as we go through this, you'll be able to note that this gives you the different signs and symptoms of Ebola. So on the 19th, the person developed joint and back pain. So that's the first set of the signs and symptoms. Then he had generalized body weakness. So as anyone, if you're feeling unwell, you're going to go and seek medical attention at a health facility. So he went to Alima Medical Center and they did malaria tests. Because why? Malaria also presents with the same signs and symptoms. So it's very hard for anyone to suspect Ebola because when you get malaria, you have all those signs and symptoms. So they did the malaria test and it was negative. On 20th, he was accompanied by his wife, the passport office, to collect his passport at internal affairs, and he vomited along the way in a public toilet. So you see how our virus is moving. So now he vomited at a public toilet. Again, you may think it's just, maybe I'm just feeling unwell, maybe I'm just tired, because health workers really, really work so hard when you're in 5 shifts in a day. And on 22nd, poor man attended night duty in Mulago. He appeared weak. And of course, as health workers, as a laboratorian, you'll tell your friend, first help me take off my sample. So they took off a sample and they did a CBC and a malaria test, again, which appeared normal. So on 23rd, he fainted in the morning after the night duty and malaria was negative. So they managed him for viral pneumonia with IV fluids. So that the disease is progressing. You see, as you're progressing, the number of symptoms keep increasing. So now here we first had the body weakness, now we had the vomiting, now we're having, it's appearing like pneumonia. So sometimes this EVD is going to present like an influenza-like illness, like a flu or something, or difficulty in breathing. So you may think maybe it's COVID or something like that. So they wanted to admit him, but he declined. Someone
Excuse
is
me,
drawing
colleagues.
in our
Please
slides.
avoid
Somebody is drawing in our
touching the
slides.
slides during the presentation.